Hello, everyone. Welcome back to the Physical Therapy Lecture Series. This is part 11, and this is on the topic of tissue issues or pain issues. Is it a pain issue or is it a tissue issue? Is it a tissue problem? So, this first slide, next couple of slides, is talking about this particular research study, but also there's several other ones like it that talk about how many people have no lower back pain, yet have a lot of different disc issues. All right. So again, this study's been replicated many, many different times, many other ones like it. Um, and this is not meant to confuse or invalidate, but hopefully validate and offer more opportunities and different ways of seeing things. So here's what's going on. Studies have like this one pulled just random people off the street who with no history of lower back pain and no current lower back pain, and given them an MRI and has seen that consistently across the board, there's always disc issues and of various sorts and types that's going on. And it's baffling, right? Because we think, oh, hey, if you have a little structural abnormality, you've got to have pain with it. But not necessarily true. So let's look at the specifics as we dive into this. In this particular study in the New England Journal of Medicine, again, they took an MRI of people with no lower back pain, and 52% had a disc bulge at least one level, 27% had a disc protrusion. And we can go down the line here and look at these different abnormalities, right? Now, that's a very hot topic, that term, abnormalities, what does that mean? Well, so maybe things we're seeing, and this is what's interesting, we're seeing these things on an MRI that might be a little bit variant or beyond what we think is a normal pattern, right? It's not quite symmetrical or not what we think that it should be, a little bit off. It's not perfect in our mind, it's beyond the perfect picture in our mind of, but there's no pain, right? So we're kind of scratching, and we always thought, long ago, hey, you got a disc bulge, you're going to have pain. You got disc herniation, you're going to have pain. Well, not necessarily true, right? And so the question is why? Well, as you're learning at this point, there are many other reasons for pain beyond just a tissue issue, right? Remember, that's just nociception. If we go back to the danger signal that goes from a body part to the brain, that nociceptive signal from long ago, many lectures ago, that can relate to a tissue issue. But that's not the only component of pain. There's the spinal cord, the brain, there's the immune system, there's all the, our beliefs, our thoughts, emotions, stressors, so many other things that are involved before we actually have a pain experience, right? And the body is very adaptive. The body is very adaptive. So you can have a little bit, or maybe even a lot of a structural abnormality. Again, what does that term even mean, right? And still not have pain. Okay, so so again, this should give you hopefully some hope that that you're not doomed. This isn't supposed to invalidate you, like, oh well, gosh, I have a disc herniation, I still have pain. No, no. Well, maybe you have a disc herniation or disc issues or other issues, whatever. You still have pain, but but maybe you can get out of pain. Maybe you can at least get less pain. You can get more functional and more comfortable. Right? Maybe it's not a death sentence, is what I'm saying, is what we're seeing. And that, maybe there's more maneuverability and workability with our bodies and what we can do to regain a functional and kind of happy, healthier life. Again, maybe there's no absolutes. Maybe there's more malleability than we think. There's more bioplasticity and neuroplasticity than we thought. And when we start to break the mold of that with our mind, whoa, that opens up new possibilities for our body. So how cool is that? And again, this is just one study in a really famous journal. There's many others like it, but hopefully that opens up some new doors. Another study here. This kind of breaks the mold of what we normally think happens with aging. So they looked at an MRI and CT. They did MRI and CT findings in individuals without lower back pain. And I'll explain this title later, wrinkles on the inside are normal. I'll explain that in a second. But here's what they found. So as people get older, right? So here, bottom down here, you see people are getting older, age 50, 60, 70, 80. We see that as people get older, the percentage of various spine issues that we would see on an MRI or a CT scan, those go up. So in blue here, we have facet degeneration. That goes up as we get older, right? We get more degeneration, and we all kind of know that. Yeah, we get a little more arthritis, right? We can also see that, yeah, we lose disc height in the red here. We lose disc height. Yeah, and we know that to be true. We've heard that, it's probably common knowledge now. That goes up. The green part, we get a little more disc bulges. That goes up as we get older. And we even get disc degeneration too, another effect of getting older, arthritis, our discs degenerate. Well, so quite a bit, right? Big increase, a linear relationship with age. So as we get older, these things increase. However, all these people who were studied who had more of these defects, quote unquote, don't have any lower back pain. Huh. Like, it makes you scratch your head, right? That's so interesting. And there's a lot of other studies like this. This is just one. And you can look at the study down here if you want to look in more detail for those of you who are more scientifically oriented. So this is why we use the phrase, hey, just like we wrinkle on the outside, right? As we age, we get wrinkles on our skin. We all do. I have them, right? I am no longer a young, you know, uh, teenager or 20-year-old, right? I'm in the aging process at this point myself. We all go through it. We have wrinkles, but do the wrinkles hurt? No, we age and we have wrinkles, but they don't hurt. We don't ever associate wrinkles with pain. Well, maybe we can say the same thing about this stuff on the inside, right? We have wrinkles on the inside. That's normal part of aging. We can, yes, it ages, but do we have to associate this with pain, or are we incorrectly associating these things with pain? Well, maybe we've been just putting too much emphasis on that in the past. Now, let's not throw the baby out with the bathwater either, right? Let's not just go the other extreme and be like, well, oh, well, you can have any structural deficit and you shouldn't have pain. Well, that's not true either, right? I mean, let's face it, it is true when things get really severe structurally, that's going to have an impact on us. So again, let's not throw the baby out with the bathwater. Let's have a healthy framework and an outlook on this and insight on things. Let's just have a balanced outlook, right? Let's bear in mind structure and anatomy and physiology with things. Just like as therapists, we look at your MRIs, we look at your imaging, but we also take that into account with your history and your exam and how are you moving and what are you saying and what are you feeling, right? There's a lot of things going in with this that we take into account. But there's no sentence that, oh, well, you've got disc degeneration and you're doomed to have pain. It's not so simple. So hopefully, again, that opens up more possibilities for you in terms of working with the body, changing the body, and getting more comfortable. Another example of the knee here, we can see an image of two knees. And when you first look at them, I always ask during a class, like, well, which person has pain, right? And most people say, well, clearly this person does, right? Clearly. Uh, you know, you can see there's no space there or very little space between the bones. There's no joint space there. And this person, these people, there's a lot more space. Well, that's got to feel a lot better, right? In that knee joint. So severe degeneration of the joint on the left, on the right, a pretty healthy knee. This one's got to be more comfortable. However, they found that up to half of people with severe arthritis in the knee actually have no symptoms. So, and 10% of people with no arthritis on an X-ray have severe pain. So, scratching our heads again. That's very interesting. So again, the structure of things, the anatomy isn't always a direct correlation to pain. There's a lot of variance there, all right? So, and as we kind of look at other just examples in research, we see that, 1 in 3 college basketball players with no knee pain shows significant issues on their knee scans. All right, so no knee pain, a lot of issues on their knee scans. 50% of people with arthritis of their knee, um, or I'm sorry, only 50% of people with arthritis of their knee have pain. Some people have an ACL tear and don't even know it. Just little tidbits of information to kind of get you to ponder and think about things. We look at demolition derby drivers. They have, and we think, gosh, they have to have a lot of pain, right? They crash over 50 times per event. They've got over 30 events in their career. And the average speed of their collision is 24 miles an hour. But only 2 to 3% have long-lasting pain, right? And we look at medically trained people in similar car accidents to non-medically trained people, they return to work 200 times faster. And there's reasons for that. Well, because we're, you know, more aware of pain and how it works in the body, and we kind of deal with it differently. So that's kind of interesting too. And then we look at the shoulder and how 1 in 3 people over the age of 30 have abnormal findings on scans of the rotator cuff, but no pain. 2 in 3 people over the age of 70 have abnormal findings on scans of the rotator cuff, but no pain. And even after successful surgery for rotator cuff issues, more than 2 out of 3 people have abnormal findings on scans of the rotator cuff. Right? It's interesting. So yeah, just to kind of think differently about this, and we can go in a lot more detail of just different body parts and different research that's been done looking at um, people who don't have pain but still have various kinds of structural abnormalities, whether it's scoliosis or cartilage tears or muscle tears, and or variant kinds of strains and problems. So again, a lot of variance there. And then we get into why. So as we get to these last few slides, oops, we go back as we conclude this whole lecture series to the general kind of overlying theme of what we're talking about, that pain is a lot more complex than just a tissue issue. There's a lot going in to our pain experience. It's not just one tissue problem. It's not just a disc issue. Pain involves multiple systems and parts of you. Yes, it's our tissues, but it's also the sensitivity of our nervous system. In fact, our neuroimmune system, our thoughts, our beliefs, our emotions play a role, our behavioral patterns, an overprotective immune and nervous system, right? That could be operating on old information, still perceiving a threat. And we look at this onion over here, this onion of layers, right? That goes into pain, that puts things into context, that it's not just a tissue damage that could be there at the core. It could have been the initial incident, or initial cause or initial event that started the pain to begin with, or it could still be happening due to a pathology or a disease state. Who knows? It could be at the core of the onion, but we've got around this many other layers that contribute and can either amplify or de-amplify. That can turn the volume up or turn the volume down, right? Emotion, suffering, behaviors, environment, all these different kinds of stressors, physical, mental, emotional, environmental, social stressors, sleep stressors, biochemical stressors, all of these things that play a role in and around you. And those are the things that we have been working with you on throughout the program, and not just in physical therapy, but throughout all the different disciplines. And whether you realize it or not, each component, each technique, whether it's through psychology or relaxation therapy or physical therapy, occupational therapy, nursing, nutrition, physicians and medicine, they all kind of work several of these components at once. It's not like, you know, physical therapy is just physical, right? It's like meditation with psychology. Well, meditation, yeah, it works, the brain and mind and the emotions, but it also helps the body too, right? And it works many different levels and layers. So there's a lot of outreach with each technique, even though you may not be able to see it. And this is just a few more slides I think we have here on illustrating, again, the multidimensional, multi-system influence of pain, how it's not just one thing. So we're working many things. That's why it comes down to creating the more we can get our life, our day to day, week to week, month to month life managed, right? Regular, get it more regular and regulated, essentially. We get more homeostasis. We get more balance. And in reality, everybody should be doing this. As I said before in some of the first few lectures, whether you're in pain or not, we should be striving for greater homeostasis and life balance for all of our systems: cardiovascular, pulmonary, musculoskeletal, neuroimmune, everything, right? And we live it's more of a comfortable life. And these things just kind of point that out, right? We go back to these things we've talked about, the effects of stress in the body, right? KD has talked to you about that a lot. The memory of pain in the system, the neurotag, the pain signature, the neuromatrix from brain to body, how our beliefs, thoughts, emotions, and mental and previous experiences play a role in our brain and pain signature and body patterns. The homunculus, right? The homuncular part of the brain, the little man or little woman, the little human in the brain, and those body maps in the brain, and how they can smudge or alter um, through movement or lack of movement, and how we can change them for the better. The neural communications going from brain to body through the spinal cord and all the nerves, right? The peripheral nerves, and how they need adequate space, movement, and blood in normal pressure gradients for nutrition, right? And signaling, and how the signaling can alter, it can amp up or amp down in the spinal cord, and how we have this complex array of biochemical and neuroimmune interactions throughout our whole system down to the cellular level, and how our nerves can sensitize on a central brain or spinal cord level, or even down at the nerve level, right, through those ion channels and nerve sensors. So, and that's just scratching the surface with things. And of course, the danger signals, the nociceptive signals going from a body part that might not be so structurally sound, right, or might be irritated going up to the brain, right? So again, another picture illustrating the multifactorial inputs to the brain from our sensory systems, our thoughts, belief, cognitions, emotions, all these things. You can read through them. There is so much involved. So I hope that this has been a valuable lecture series to at least start that process of illuminating the complex interrelated nature of pain, but to give you insights and new directions in how to self-manage your pain process and to live a better life, right? And feel more comfortable, happy, and more functional in months to come. So thank you again for your time. I really appreciate all of you and your input. I will uh, talk to you soon.